over to Nishant, and that will be for. And so after Nishant, it will be Uma. So the global perspective of stroke and COVID, and then followed by the Indian cases of stroke and COVID. So over to Nishant.
Thank you, Dr. Hastak. Such an honor to use my screen. Okay. It is such an honor to be speaking here at this forum in front of my mentors, Dr. Hastak, Dr. Kaul, Dr. Sundar, Dr. Oja. So today I'm going to talk about stroke in this ongoing pandemic, COVID-19. All the opinions are my personal opinion. I have no conflict of interest. And speaking here on the personal invitation from the Stroke Society. So look at this picture. This is our famous Times Square in New York. And we are living in this situation where we hardly see any individual, like very few people. It's usually crowded.
Nishant, your screen is not yet shared, you know. You have not shared your screen as yet.
That's right. That's right, Pawan. He's right.
I shared, no?
And friends, Dr. Pawan Oja and Dr. Subhash Kaul, of course, they don't need any introduction. So they're a part of our stroke.
Just below the participants chat, there is a green thing called share screen.
Okay. And then we go here. I think it was shared before. Okay. And
yes.
Yeah, got it. Yes, correct. Yep, now right.
And the other people can now switch off their videos, you know, the Dr. Uma Sundar and Dr. Shirish, so that the speaker.
Yeah, agreed. Let's do that. Yeah.
All right. So thank you, Dr. Oja, for correcting me on that.
Welcome.
Okay. So, so I was showing this picture of Times Square. It's on a typical day, pre-COVID times. So it would be usually like crowded with like thousands and thousands of people, tourists. And we are living in this situation now where because of the pandemic, we have hardly any people like going out on the streets and doing the social distancing and all that stuff to save the resources and also prevent the spread of the disease. The data from a few days ago suggests that worldwide we have more than 3 million cases, almost 200,000 patients and more have died. In the United States itself, we have more than 1 million patients with more than 60,000 patients who have unfortunately died to this invisible enemy. In New York, New York and New Jersey, we are called the epicenter of this whole pandemic in our country here. And I'm also saddened to see that the numbers are gradually going up in India with more than 1,000 deaths and more than 30,000 cases that have been reported. So the COVID is mainly known for the respiratory symptoms. It's caused by the SARS coronavirus. It's similar to the one which had caused this epidemics in several countries in 2003. Both share the same mechanism of causing infection. They attach to the ACE receptor 2. The pathology that's particularly notable in this condition is it causes pulmonary edema, cerebral edema, and also microvascular steatosis. In the context of neurologic symptoms, initially the symptoms can be trivial, they may be non-specific, and that poses the risk of causing delay and misdiagnosis. And it's usually the patients with severe SARS-CoV-2 infection that cause impaired consciousness, encephalopathy, and skeletal muscle injury, like Dr. Hastak was earlier telling. It's a beta subtype of coronavirus. There is nothing novel about it because this virus was known, just that the coronavirus type 2 is the new one, which has come into prominence and spread out worldwide to cause this terrible disease, taking huge count on human lives. It attaches to ACE2 receptors, invades the epithelium. We have no evidence yet that it causes CD4 cell count decrease or invades that. So the mode of transmission of this condition, it's largely by droplets, possibly also contact. And that was the case earlier. It's definitely also by contact. It stays on the fomites for 4 days, even longer. It can stick around in the aerosol for several hours. Transmission can occur up to 8 days after the start of illness. Live virus, the nucleic acid, they have been detected in the stool. And now there is also this recognition that we have so many asymptomatic carriers who can potentially transmit the disease. So very highly contagious disease, very highly contagious organism, long latency. Like we talk about incubation period up to 14 days, but then there are also a few patients who had incubation period up to 24 days. In fact, there was a news article from Wuhan that suggested that it was even longer in one patient, like up to 30 plus days after the infection. The risk factors include, if you have visited the epidemic area, there is a history of contact to patients who have coronavirus infection or disease. Symptoms, we are all familiar with that. It's usually the fever, dry cough, fatigue, abdominal pain, diarrhea, conjunctivitis, and the disease of our interest today, which includes all the neurologic symptoms. From the lab standpoint, we see elevated LDH, low procalcitonin, high CRP, high D dimers, reduced ESR levels, low BNP, variable levels of troponins, low WBC count, hyponatremia, elevated LFTs, high ferritin. Patients usually present with respiratory symptoms. There is hyperactivation of the inflammatory factors, which causes the storm of the symptoms, followed by, or also includes other mechanisms by which it affects the coagulation system, causing venous or arterial thromboembolism. Most patients would have low-grade fever, but there are also patients who will have high-grade fever. Some patients will complain of difficulty breathing. Some will have significant difficulty breathing. I'm sorry, there is this thing which is coming on my screen again and again. Let me throw it away. All right, thanks. Some patients will have very bad looking lungs on the CT scan, but may not have fever at that point of time, but they would complain of severe weakness or exhaustion. There will be others who will show improvement in their temperature, in their fever, but their pneumonia will worsen. And it's usually the patients with severe COVID disease who manifest with the neurological problems. Common symptoms being dizziness and headache, but also includes impaired consciousness, strokes, ataxias, epilepsy. From the peripheral nervous system standpoint, patients have dysgeusia and anosmia. They have vision impairment. Some have neuralgia. And from the skeletal system standpoint, they have pain, also associated with elevated CK. So in this condition, COVID, there are different stroke mechanisms which have been reported. The severe infection causes increased inflammatory response, increased coagulation. What exactly happens is that there is an increase in the cytokine levels in the serum, in the blood of the patient, which damages the endothelium. activates the mononuclear cells, and which activates the tissue factor. This tissue factor causes the thrombi to circulate in an uncontrolled fashion because of elevated levels, and natural anticoagulants do not work well. There is increased risk of thrombogenesis. This organism also binds to the ACE2 receptor, which can potentially cause fluctuation in blood pressure. It can also cause thrombocytopenia, and these two mechanisms can potentially explain the hemorrhagic strokes in this patient population. And then these patients have the typical risk factors for stroke, which include hypertension, hyperlipidemia, smoking, prior stroke. There was this study reported in Lancet, a single center study, retrospective in nature, observational, from Wuhan. They studied about 200 patients. Of them, 11 patients had acute ischemic stroke. One patient had venous sinus thrombosis, cerebral venous sinus thrombosis, and one had cerebral hemorrhage. Of those 11 patients who had acute ischemic stroke, 5 had LVO, large vessel occlusion, 3 had small vessel disease, and 3 had cardioembolic stroke mechanism. The one with the venous sinus thrombosis was a younger patient. His age was 32. There's a typo on my slide. Other patients were mainly elderly. The median duration from the onset of infection to stroke in this patient population was 10 days. But if you look at the interquartile range, it was anywhere between 1 to 29 days. So the stroke patients were significantly older. They were more likely to have very severe COVID. They were more likely to have other cardiovascular risk factors like hypertension, diabetes, or the prior history of stroke. These patients showed increased inflammatory response. They were in increased state of hypercoagulability. The CRP levels were significantly elevated, and so were the D dimers. This Chinese group treated these patients, 6 of them with aspirin or clopidogrel, 5 with anticoagulation. Of the total, 5 died. This is another letter published in JNNP by a group from Queen Square. They reported about 5 patients. I'm just going to tell you a story of one patient from that article, a 64-year-old guy. At about 10 days, like his symptoms started with usual respiratory symptoms, breathing problem. Around 10 days into his disease, he began to have respiratory failure, which required admission to ICU. He was noted to have mycoplasma pneumonia infection and treated with clarithromycin. Around 15 days of the symptom onset, he developed mild left arm weakness and incoordination. MRI showed that there was a left vertebral artery occlusion and acute left posterior inferior cerebellar artery territory infarction with some petechial hemorrhage. D dimer was elevated. He was treated at that point of time with aspirin and clopidogrel. 4 days later is day 19 of the COVID. He was noted to have bilateral pulmonary embolism. And at that time, he was being treated with low molecular weight heparin at therapeutic dose. On day 22 of his COVID, he developed acute bilateral incoordination and also vision problem. His MRI showed that he had extensive PCA territory infarction and then received a high intensity low molecular weight anticoagulation. And the other 4 cases that they describe in this article, they are also of the similar nature, patients with COVID and inflammatory situation or hypercoagulability, treated with antithrombotics. They all had cardiovascular risk factors together with the COVID infection. And that begs the question that with these data of fewer patients and patients harboring the cardiovascular risk factors, can we argue that there is a causal relationship between the patients with this viral infection and ischemic stroke? This is another article that came from Mount Sinai group a few days ago. Got a lot of limelight in the news, in the media, by Tom Oxley and colleagues. So our group reported 5 patients. They're all younger. The oldest patient is 49-year-old. The youngest is 33. Most of them are males. 3 have cardiovascular risk factors. They had a pretty significant stroke at baseline, an Ash stroke scale of 19, 13, 16, 23, and 13. They all had significant stroke in different vascular territory, as is listed here: right ICA and left MCA, right PCA, left MCA and right MCA, in patients 1 to 5. And they were treated differently with apixaban, depending on the standard of care applicable at the point of their admission or arrival to the hospital. They all had COVID symptoms, except one: cough, headache, chills, lethargy, fever, cough. One had no symptom but was recently exposed to a family member with PCR positive COVID. And then there was another patient on whom we have no suggestion of COVID symptoms. But labs are abnormal. The PTs are elevated in some patients. Fibrinogen is elevated in some patients. So there are some abnormalities at the level of that. But these patients, again, harbor some cardiovascular risk factors. But the limelight here is that these patients are younger, and stroke in young has been an interesting topic. But I think our colleagues in many developing countries, in India as well, like we have experience of seeing patients, younger patients, in the context of infection like tuberculosis or cysticercosis or CMV infection, HIV, mucormycosis, aspergillosis causing brain infarctions, and so the strokes of infective etiology in younger patients. We see them. This is definitely interesting because we are seeing these patients in the context of SARS-CoV-2 infection. And given the magnitude of the pandemic and the risk, the high risk of spreading infection, even amongst the healthcare workers, there has been a lot of debate, and the workflow of caring for these patients has been modified so that we are able to offer the best quality of care to our patients while also keeping our colleagues safe and being mindful of the utilization of the resources. Because as has been in the news, there are certain resources like PPE, for example, which are invaluable, and we need to save them for our colleagues. So Biller et al. Have made this suggestion that stroke community needs to relax guidelines and stroke pathways while continuously providing high quality of care, including treatment algorithm post IV TPA monitoring, diagnostic workup, disposition planning, preventive measures in order to offer the optimal care to the patients, but at the same time minimizing the chances of spreading COVID. Interestingly, there are data that suggests that there are fewer calls for the stroke symptoms or stroke codes in several jurisdictions. Like there are data from Chicago, for instance, where the EMS calls for stroke have reduced by 20%. There was one paper from an Italian group where again, the stroke codes were fewer in number. Don't know whether the patients are scared of the COVID and that's why not calling, or the resources are not available for that particular reason. So we need to really encourage the patients, the providers to spread the message that they should call for help if they are suffering from symptoms suggestive of stroke. And then at the level of emergency room, at the level of triage, while doing the standard stroke triage, one also has to discuss and screen for the COVID symptoms. Telemedicine is invaluable. It's serving a great purpose in this context. For instance, someone with mild stroke or someone not requiring an acute intervention can be treated differently. One can figure out based on tele-neurology or tele-video, telemedicine evaluation of the patient, whether an immediate hospitalization is necessary. One can get the arterial imaging at the spoke site, at the peripheral site, review the images, and then decide on bringing the patient to our center. And then decide on bringing the patient to our center based on our clinical judgment, whether the patient will derive a meaningful benefit. One can get the sense of the patient underlying comorbidities and decide if the intervention would be worthwhile for the patient. At the level of pre-hospitalization, it's also important to consider that in the communities where there is a widespread spread of this virus, and many people could be asymptomatic carrier, it's very important to presume that most, I would say every patient who shows up as a stroke code is a person under investigation. And it's important that even though we recognize that clinicians are superheroes, we should avoid sacrificial actions. Our actions should be meaningful in the best interest of the patient, while also safeguarding ourselves and our other patients. So before the stroke team evaluation, the patients should be screened for the COVID symptoms. One can use the telestroke to obtain the contact information, the collateral information, can obtain the consent. A verbal consent should be fine if the patient is eligible for TPA. One should be looking for not only the COVID symptom, but also can just look at the vitals and saturation, breathing rate, the patient's temperature, and can get a sense of the possible COVID. While putting on the PPEs, it's important to have a safety buddy who ensures that you're donning the PPE correctly and there are no loopholes. There should be a designated location in the ED where you are managing your stroke code, which does not contaminate the other neighborhoods or location in the ED. And have to offer the standard of care, IVTPA, TNK, with or without endovascular therapy. But at the same time, be mindful of possibility of avoiding hospitalization in situations where one can potentially complete the workup while the patient is still in the ED, like for instance, the work of our TIA or lacunar stroke. And the screening for the COVID should have happened or should be done even prior to the stroke team evaluation. And given the magnitude of the problem, the burden of disease that this condition has posed on the healthcare system, we are in a kind of a crisis mode. And as I was mentioning earlier, one has to make best clinical judgment to offer the best treatment while also avoiding futile reperfusion. Have to take into account the life-limiting comorbidities to gain an estimate of the longevity of the patient post-procedure. One has to start thinking in terms of rehab needs, the code status at the very outset. And in that context, getting connected with the healthcare proxy is useful. We are using these patients' tubings from outside, like putting them outside and trying to do the video evaluation or video surveillance in the post-admission phase of these patients. And have to take measures to avoid, prevent, reduce all the aerosol generating procedures. There are recommendations, there are articles from our anesthesiology colleagues that even though in a typical situation, one would want to do general anesthesia, but given the risk of offering that to these patients, conscious sedation is preferred. And have to make a judgment about who you would intubate, where you will intubate. So these should be negative pressure rooms, for instance. Before the patient gets to the thrombectomy suite, for instance, the room should be prepared and all the unnecessary items have to be taken out. Have to take measures to minimize the breaking in and breaking out in a thrombectomy suite, for instance. The control room is also a positive pressure room, just like the endovascular suite. People have to put the masks. Keep the things out that are not needed in there. So keep the pagers, phones, make sure that trash can is like you throw the trash in the trash can and save our colleagues, the cleaners, from getting infected. During the procedure, there can be one nurse, one technologist, one physician in the endovascular suite. Tape the doors so that there is, again, no breach. Maintain euvolemia in these patients. These patients are more likely to go into pulmonary edema, ARDS, so you want to keep slightly negative or euvolemic, avoid blood loss. It's a treasure these days. And for the post-procedure time, decide beforehand or make a good list of all the labs that are needed to be sent, so that again, the lab tech also needs to use PPE and we are able to save it and we are not doing unnecessary testing. Certain testings which can wait until after patient's discharge can wait, and we should save resources by doing that. So we are all familiar with the standard of care, the TPA endovascular procedures. Ever since the data emerged for the safety and efficacy of endovascular procedures in the stroke world, we were redesigning our system of care to offer the best care to our patients. And the COVID-19 has put in a new angle and new challenges when it comes to offering them the best care that they deserve. And I think that the teleneurology has a great role to play, and more so now. And And I think we should build a program, develop a program wherein we are able to offer these therapies using the teleneurology and getting the story from far away from the patient, getting ready beforehand so that we are well prepared for the patient, while also reducing the risk of spreading infection. And then teleneurology is just not only for stroke. You can find great use in managing, diagnosing other conditions, like movement disorder, for instance. And the big problem is that there are very few neurologists, and not everyone is doing stroke. There are neurologists who do multiple sclerosis and movement disorder, and so the resources are few, and we need to perhaps create a system such that we are able to offer training and expertise to the colleagues who are not neurologists, but can be trained to manage stroke patients. And then there can be a scope for using teleneurology to coordinate with these colleagues and share knowledge. And in that context, I think I like the British model where people from clinical pharmacology or cardiology or other medicine background spend about 2 years doing a stroke fellowship, stroke training, and gain expertise in managing these patients. And then there have been several viewpoints about it, like who should be managing stroke patients? A general physician, a general neurologist, general rehabilitation specialist. They're not really qualified unless they are specifically trained. And as Louis Kaplan says, that what is more important is interest, training, and experience in caring for stroke patients. So from the future direction standpoint, I think our practice of medicine will have a lasting impact from this invisible enemy, COVID-19, SARS-CoV-2. We need to create pathways so that we are able to offer the most efficient and safe care to our patients. We should perhaps, I think, encourage teleneurology to the students and trainees. One can potentially reduce the risk of exposure to them by offering webinars like this. And more importantly, this is a new experience. We should perhaps build a registry, collate these data, publish them, share knowledge between us so that everyone benefits from the knowledge. Thank you.
Dr. Uma Sundar, yeah, please go ahead. You're going to show the cases, so that's going to be, again, a very interesting part. Go ahead, Dr. Uma Sundar.
Thank you. Good evening. Thank you, Dr. Mishra, for that wonderful lecture. I also thank the Mumbai Stroke Society for giving us this platform. I'm going to talk about our experience in stroke. I belong to the Lokmanya Tilak Municipal Medical College and Hospital, popularly known as Sion Hospital. And we are in the unique position here of caring for both COVID and neurology and acute stroke services. Particularly, we drain two of the very densely populated hotspots of Mumbai, Govandi and Dharavi, which have recorded the maximum number of cases of COVID. I'll give you a short background of COVID in our place. This is yesterday's data. We have seen 336 COVID positive patients so far and 166 COVID negative severe acute respiratory illness. And these 166 patients actually are probably all COVID positive, And it's only because in the earlier days, we were not doing 2 swabs, or some of these patients expired early before the second swab could be done, that these were not recorded as COVID positive. And we have seen ischemic strokes in COVID 3 in the last 2 weeks, which roughly gives a percentage, if we take the COVID positive as the estimator as 0.89%. But this could be an underestimation, because I think in the early days, when we were still learning on the ground, we may have missed some ischemic strokes, which were possibly due to COVID. And also, we have recently started doing chest CT for hemorrhages, and this incidence might go up. I'll just take you through a short COVID severity classification, because it puts the context of our strokes in which part of this COVID severity it comes from. So we have the group A, B, and C, which are basically asymptomatic COVID positive or with very mild upper respiratory tract infections with or without comorbidities. And we have the group D, E, and F, which have lower respiratory tract involvement, either with hypoxia or without hypoxia. In the most severe stages, E and F requiring ventilator, and finally having severe pulmonary involvement with a cytokine storm and having multi-organ dysfunction. So this is important because 2 of our patients were in group E and F, but one of our patients was actually initially in group B or C. So now I will start with the cases. So this was a first case, which is a 55-year-old male. He came with a left hemiparesis and drowsiness since 3 hours. He actually did not have any cardiac, any vascular risk factors, no addictions. He had a history of COVID contact in his neighbor and belonged to a highly population dense area. And on inquiry from the relatives, they gave a history of mild fever and rhinitis for 1 day, but there was no breathlessness. His pulse and BP were normal. Respiratory rate was 24 per minute. He had normal lung findings on clinical examination. Pupils were equal and reacting, but he was drowsy, requiring repeated calls to attend. There was a left hemiparesis with a left UMN 7th and an NIHSS score of 16 to 17 at admission. His oxygen saturation was 93% on room air at admission. His electrolytes, blood sugar, and creatinine were all in normal range. His chest X-ray showed these bilateral hazy peripheral shadows. His CT scan showed a right-sided parieto-temporal infarct with a right MCA cutoff. This was a fairly large infarct, and the aspect score was going to be low, below 6. And his CT chest showed patchy areas of ground glass opacities in subpleural location in both lung parenchyma, which was like atypical pneumonia, but in this setting, it was very suggestive of COVID-19. So one can see these very typical peripheral subpleural dense areas, which are rounded in some places. This is a coronal view of the same, and the sagittal going right up to the episis, in fact. So since this person had a large parieto-temporal infarct with low aspects and an M1 cutoff, signified a large artery thrombosis, he had an M1 block. What was possible in him logically was either an IV plus MEC or a MEC thrombolysis, because the clot burden was too high to just give an IV thrombolysis. But because of the low aspects and increased possibility of bleeding in this patient, we actually did not thrombolyze him. We gave him double antiplatelet statin and mannitol, and our standard therapy for critical COVID patients, that is HCQS, azithromycin, oseltamivir, 80 milligrams of methylprednisolone IV, and high flow oxygen. His throat swab positive report was available after 16 hours. It was positive. We did not give LMWH heparin either, because I thought that he might bleed. The second case was a 60-year-old male, hypertensive and diabetic, recently detected, 8 months, right-sided weakness for 2.5 hours. He had no history of COVID contact, but he had fever and dry cough for 2 days and breathlessness for the last 3 hours. His pulse was 96 per minute. BP was high at 190 by 100. Respiratory rate was high. He had bilateral crepitations. His oxygen saturation on room air was only 70%. But this patient was actually able to hold his breath for the chest CT despite this low oxygen saturation. He was alert, had a right UMN facial weakness, right hemiparesis. NIHSS was 5 to 6 at admission. Creatinine was borderline at 1.4, and blood sugars were also high at 390 milligram%. He had a subtle left central semi-ovale infarct, which you can see in the CT. In this patient, actually angiography was not done due to some technical reasons. And on the CT, we saw patchy areas of ground glass opacity, subpleural location in both the lung parenchyma. Again, very suggestive of COVID-19. You can see the rounded, hazy shadows at the periphery. And he actually had very extensive changes on the CT chest, extending up to the mid and right up to the upper zones in the left side. The sagittal view. So he had this left centrum semi-ovale infarct. Aspects was good, more than 7 at admission. Angiography was not done. Here it was a little difficult decision. We did not do IV thrombolysis, as initially I felt that the NIHSS was borderline low. 3 hours had already elapsed. He was diabetic and did not really qualify for the 4.5-hour window. Additionally, his respiratory status was poor. His sugars were a little high. His blood pressure was 190 by 100. For these reasons, we did not thrombolyze this patient. However, this patient deteriorated at 2 hours to NIHSS of 14, causing us to question our initial decision. And also, in retrospect, probably this patient had a large vessel proximal occlusion leading to progressive cerebral infarction, and maybe he initially had only the penetrating vessels suffering the insult, and later on he might have had a cortical infarct also. And his throat swab positive report was available after 12 hours. Case 3 was actually a patient whom we found on going back through all our cases over the past 45 days since we've started managing COVID. And this patient actually did not come in with an acute stroke. That is why it was not referred to my unit initially. She was a CKD on conservative treatment 2 years with hypertension. And she had come with the 1 full day of history of slurred speech and right-sided weakness and drowsiness. She came only after 24 hours. Her vitals were stable, oxygen saturation at admission was normal, and neurological examination showed a right hemiparesis, grade 3. Patient was drowsy but responding to calls, pupils were reacting. We don't have an NIHS score in this patient at admission. She was not in the acute stroke protocol. So she had an ill-defined hypodense area in left frontal region with hyperdense area within, query a hemorrhagic infarct. And she actually had a CT angio done. I think the CKD was found later, but her creatinine did not actually worsen after the CT angio. However, she did not have a CT veno done, so we do not know whether this hemorrhagic infarct, what it was due to an embolic arterial or a venous. It probably was an arterial infarct, but I'm not sure about that. Now, this patient had no respiratory symptoms at admission at all, but on the 4th day after admission, she developed fever, and a chest X-ray was found to have peripheral haziness at the basis. She was initially admitted in the general medical ward, but at this point she was transferred to the COVID suspect ward and her throat swab was sent. And her first throat swab 5 days after the onset of weakness and 1 day after the onset of respiratory symptoms was negative. However, the CT showed ground glass density in the apical and anterior segment of the right upper lobe, the apico-posterior segment of the left upper lobe, and the superior segment of the right lower lobe. So the CT showed the extensive changes of COVID. Because of the high suspicion, her second swab was sent due to persistent symptoms 4 days after the first, and this was positive for SARS-CoV-2. She subsequently developed type 1 respiratory failure and expired after 3 days. And so this patient did not have respiratory symptoms when she came in. She only had the stroke. So these 3 cases are what we have seen, and this brings us to some of the questions which were discussed actually when I showed these cases in the Mumbai Stroke Society in our WhatsApp group. So whether any of these were incidental COVID positive with stroke versus COVID causing stroke was one of the questions raised. I think Dr. Ocha had raised this question. So especially since the presence of vascular risk factors and presence of large artery thrombus can be seen in both, just having a COVID positive asymptomatic with stroke can also have this. In our patients, the COVID symptoms, 2 of the patients had COVID symptoms in group D, E, and F, but one definitely was in group C when she came in, or group B, and only developed respiratory symptoms later on. But if we look at Dr. Thomas Oakley's report, which Dr. Mishra has highlighted, I noticed that hardly anybody among his 5 patients had any respiratory symptoms except for lethargy or headache or very mild fever and cough. And I think 1 or 2 patients were totally asymptomatic for respiratory infections. And although Dr. Oakley did mention that the first case had CT chest findings, I did not find any of the other patients' CT chest findings. Perhaps Dr. Mishra has access to the raw data in this, but I did not find this, nor were the oxygen saturations mentioned. So I'm wondering if his patients, some of these were just incidental COVID positive with stroke, or truly they were COVID causing stroke. But in our patients, they really had respiratory symptoms and the CT chest. And I think there was no doubt this was COVID causing stroke. So if one had a CT chest typical of COVID, a D-dimer fibrinogen, there would not be any doubt. The other important point, of course, is the throat swab. Low sensitivity of a single nasopharyngeal swab, which is about 63% only in the best possible scenario. And so, as seen in our third case, we might have to repeat it once more to get a positive. So what we learned about diagnosis from these three cases was that respiratory symptoms and signs can be absent, mild, or very early neurological presentation can occur. The syndrome of happy hypoxia, patients appearing to tolerate low levels of oxygen saturation quite well till sudden deterioration. This is very true. And this is because PCO2 washout is good. There is no PCO2 build up. The dead space is not increased, and the lung compliance is quite good. So they tolerate hypoxia till quite late. Of course, if we have a history of COVID contact, respiratory symptoms and signs, low oxygen saturation on oximetry, and residence in hotspot areas, these factors should alert us. Our protocol is for doing CT angio. Now we do a CT chest for all strokes. I have a small question about this. We do a CT angio without thinking about the creatinine as for all our acute strokes, unless there is some clinical evidence that a patient is CKD or has a renal problem. But of late, acute renal failure has been described in COVID, and whether we should be more vigilant about this before doing the CT angio is a question. We should probably do a CT venography also in all our patients. And we should do a repeat RT-PCR throat swab if our suspicion is strong and if the first report is negative. Now, in a setting of any thromboembolic phenomena with COVID, one would do a D-dimer, fibrinogen, APTT, ferritin, triglyceride, perhaps even APLA, ACLA, besides the usual CT angiography and 2D echo. Now, for us in our resource poor setting, this is a real challenge. And especially when all our available resources are already stretched in the pandemic setting. So we will probably have D-dimer and ferritin soon, but it's yet to come for us. Now, what we did in our patients, in our first case, we thought he was a poor candidate for intravenous because of the large clot burden. So we had the option of either going with IV plus MEC or MEC, but his low aspects and his risk of bleed made us decide against this. In our second case, we had no angio, but possibly we could have done IV thrombolysis, but I thought NIHS was borderline low and 3 hours had elapsed. Additionally, his respiratory status was poor, but this was a gray zone, which perhaps we could have done it, but it was going to be very difficult with such a bad respiratory condition. Case 3, of course, presented after 24 hours. Now, Dr. Mishra has already discussed these, so I will not go into any of these, except to mention that the neurological manifestations of hospitalized patients with stroke, Mao et al.'s Chinese article, I had a small doubt about whether the peripheral nervous systems described of loss of taste and loss of smell, whether they were truly neurological or whether they were due to local invasion of the virus, of the mucosa by the virus. That's just by the way. And of course, I always also want to mention Dr. Umapathy's article of large artery ischemic strokes in the original SARS in 2003 and 2002, which was reported in Neurology 2004, an incidence of 2.5% at that time, and which was actually treated with IV immunoglobulins at that time as it was thought to be autoimmune. So I just want to mention that AHA Stroke Council leadership has advised adherence to existing guidelines for thrombolysis, with the important caveat that in the COVID-19 setting, adherence is a goal, not an expectation. And our own expert group on behalf of the Indian Stroke Association consensus statement released on April 23rd, Dr. Kaul sir has been as a part of this. And it says individualized decisions will need to be taken for patients with a serious COVID-19 illness. And I think this is what we faced. So I just want to mention that IV thrombolysis one may want to do this not only because of lysing the clot in the brain, but also it may help the lungs too. Increasingly, we are seeing that there are reports of thromboembolic phenomena elsewhere. For example, the Italian study, the pulmonary postmortem findings, COVID-19 cases from northern Italy, which showed small arterial thromboembolic phenomena in the pulmonary vessels. On the other hand, there is an increased risk of bleed because there are cytopenias, the Chinese study showing thrombocytopenia. So whether we really need to do platelets in these patients, we need to have that report and the creatinine report before we thrombolyze these patients. But by the way, we have not seen much of thrombocytopenia in our patients. By and large, they have been about 1 lakh. Now, also, I would like to add the caveat that most of these articles that are appearing, they're all, none of them is really peer reviewed, and we're all fast tracking publications. So whether they will stand in the long run, I'm not sure. But there is a clinical trial to assess TPA in COVID-19 related ARDS. And this is only in ARDS. This is not in a neurological indication, but for the pulmonary indication. Mechanical thrombectomy is a big question. I don't think I will comment further on that. Again, LMWH or conventional heparin in COVID with stroke and in COVID per se without stroke. I would like to just elucidate a bit on this. We give enoxaparin if there is sepsis-induced coagulopathy. That is, if there is an SIC score of more than 4. This score is obtained by looking at low platelets less than 1 lakh, high INR more than 1.4, and a SOFA score more than 2. The SOFA score is important in that it does not take into account the CNS. It is a liver, lung, hepatic, and kidney score. So there's no internal conflict within the score. And if this consolidated score is more than 4, or if the D-dimer is raised, then we start enoxaparin. Now this SIC score is actually telling us that this patient may go into DIC. Once we have the D-dimer high and we have the fibrinogen low, then we have, and the PT-INR is raised, then that patient is most likely going into DIC. So this actually looks at group E and F of the COVID, which the severity group which I had shown earlier. And enoxaparin is given in our wards for these patients. Now, interestingly, heparin has anti-inflammatory, anticoagulant, and antiviral properties. It binds to a protein receptor on the surface of the virus. So there is a lot of interest in heparin as a treatment for the disease. And there is an article by the Chinese author, as I've shown you over here, anticoagulant treatment associated with decreased mortality in coronavirus 2019. But in the setting of COVID with stroke, I would be worried about increased risk of bleed and large infarcts, especially as these infarcts are supposed to be secondary to a large artery thrombus. Our treatment is HCQS, azithromycin, oseltamivir, 80 milligrams of methylprednisolone daily, and high flow oxygen. This is entirely empirical. Now, we know that none of these treatments have been proven, and all these treatments, all the advisory boards the world over have said that this treatment should be given only in the setting of a trial. But failing, not having anything else really to offer our patients, we are giving this. And we are switching to lopinavir, ritonavir also, if the HCQS causes QT prolongation. Now, my feeling is that the empirical treatment for COVID, which we are giving, may not adversely affect stroke, but whether what we are doing for stroke, that is treating the cerebral edema with mannitol or Lasix or glycerol, whether it might worsen a generalized thrombotic tendency, I feel it is a possibility. I've shown you this very, very busy slide, not to be able to read anything. I myself cannot read much in this, but just to show you that these green areas are the ones where there is some evidence for the mechanism of action or for the strength of scientific evidence of any of these drugs. And as you can see, there is nothing green over here. There is nothing green of strength of results at preclinical stage, nothing at all. The only green is in some safety studies. So as of now, we do not have any licensed treatment at all. Although we are following awake repositioning and proning protocol in some of our patients, The use of these in patients with stroke would be difficult and dangerous, and this can usually be used in early stages only. Our anesthetists who are manning the ICUs in Seven Hills are using a lot of this, but in the presence of stroke, this may not be possible. And as far as we are aware, there is no data on treatment with antivirals, IL-6 inhibitors, or plasma exchange affecting thromboembolic outcomes, but we might hear more on this down the line. Thank you very much. And I particularly want to thank my residents and faculty who are at the front line of this. Thank you.
Thank you. Thank you both Dr. Uma and Dr. Nishant for excellent talks. And I think Dr. Subhash Kaul is there online. So Subhash, would you like to make a comment or a question?
Yeah. So first of all, I also want to congratulate both the excellent speakers with a lot of insights, both international as well as Indian. Thank you very much. My question is to Nishant first, and Uma can also probably give a comment. I have also studied this area of stroke in COVID. And what I have realized is that the management of stroke in COVID is exactly like a normal management of stroke. There is no difference at all. Whether you take indications, whether you take contraindications, whether you take TPA, whether you take endovascular, this is exactly similar, even as per as AHA. So we need not worry about it, that how we treat. It's to be treated like you treat any other stroke. But my question is, the one which bogs us all the time, is that when a stroke patient comes to us, can that be the only manifestation of COVID? Particularly in patients who do not have fever, who do not have cough. Now, many people have asked me this question. So my question to Nishant is that should we screen every stroke patient for COVID? Because you never know, this may be the manifestation, particularly in the patients who do not have any fever, cough, or respiratory symptoms. Should we screen every stroke patient for COVID?
Thank you, Dr. Kaul, for asking this question. As we know, there's a huge big prevalence of patients or individuals with who are asymptomatic with COVID. I think in the current scenario where the epidemiology standpoint, it looks like almost everyone, for example, in the state, in New York, for instance, many people have COVID infection. They may have mild symptom, they may be asymptomatic, or they may be having severe symptoms. Now, I think a methodology by which we can potentially answer this question is by keeping an account of these patients, doing the testing for COVID on these people, looking at their inflammatory markers, all that, and kind of building a registry so that over time, when we have more data, we're able to look for association. Again, association is not causality, but at least that will guide us in certain direction.
So no, as of today, if a patient of stroke comes to you, who's asymptomatic for respiratory symptoms, would you presume that he's COVID? In other words, would you take all the same precautions and, or you will take him as a non-COVID patient?
No, I think I would still consider him as a person under investigation.
Okay.
Yeah.
But what you said is that you would do a CT chest in all stroke patients, irrespective of their symptoms. Would you still do CT chest, or no, it's not necessary if they are asymptomatic?
I think in these times, we should perhaps look at, we should do the repeat testing, because it's not a sensitive test when it comes to the reverse RT-PCR. One can look at the serum for the IgM levels for the antibodies, and because there have been patients who were negative for the RT-PCR testing, but ended up showing IgM elevation from the antibody standpoint. So that can potentially.
What about CT chest, CT scan of the chest in the asymptomatic patients? Should we do that?
I would lean towards not doing it.
Okay.
Yeah, I would lean towards, because one should be mindful of the resources. And
Okay.
if patient is asymptomatic, not having any problems from the dyspnea standpoint or a saturation standpoint, then perhaps it's not needed. But I would definitely be considering testing for or exposure or underlying recent infection.
And how useful is D-dimer practically in your experience? Because D-dimer as such can be raised even in a non-COVID stroke. But in the COVID setting, it has been reported to be very high. I mean, it can be 30,000, 40,000. But in practical terms, is it really useful for us to suspect? I want to know about you, because D-dimer is possible. We can do it easily. So can you make a comment on D-dimer and ferritin as far as day-to-day management is concerned?
I think they are only suggesting that there is a lysis of the fibrinogen and D-dimer is getting produced. And as you said, like it can be from various mechanisms. As far as the level of ferritin is concerned, that again is a marker of like underlying inflammation, which and it's known to increase, for instance, in the context of influenza or a prolonged inflammation of any other etiology. When we are seeing those levels elevated in the context of patients with COVID exposure, SARS-CoV-2 exposure, then we are linking them together. But so it's the clinical context. I think it's putting them all together gives an indication or suggestion that they are linked. But you are totally correct that they can be elevated in other scenarios as well.
And Nishant, my last question to you is that we talk a lot about sanitization of the angio suite, sanitization of the MRI. So, you know, in a setting that where you have done mechanical thrombectomy in an angio suite, and you have only one angio suite in your hospital. Now you have to do on other patients, and you somehow suspect this could have been a COVID. Now, what is the sanitization? How do you do it? How much time does it take? And because we really don't have experience of this, sanitizing the entire imaging infrastructure.
Yeah, I haven't directly dealt with the sanitization thing, but I do know that, for instance, UCLA, which is a big MRI center, and merely to avoid the contamination, they have, what I recently heard is that they have switched to also doing the CT and CT perfusion. One can potentially separate the imaging resources based on your level of suspicion for it to be, COVID or not. And obviously one has to sanitize after the imaging is done. And then that also begs the question that what is the clinical necessity or the level of benefit that we are going to derive from doing certain kind of imaging on patients. Say someone who has a poor Rankin score, does not have prolonged, long longevity because of the underlying comorbidities. I mean, it's inhumane to make such a suggestion. Like in a typical scenario, we would do that, but we would offer treatment. But then here comes the question about how to best utilize the resource and offer it to the person who has the best chance of deriving benefit.
Thank you, Nishant. Thank you very much. Shirish, please go ahead.
I think Uma can then talk about the Indian scenario. What would you do to a patient who's asymptomatic, otherwise from COVID point of view, but has a stroke? Is young, is old, is diabetic, hypertensive? Would that change your thinking in terms of how much you would investigate?
Actually, one of our 3 patients had this, in fact, came with a stroke, and 3 to 4 days later developed respiratory problems. So in that very limited experience of 3 patients, we did see this. So I would, so we are now doing CT chest as part of our protocol. And we would check oxygen saturation for everybody who comes in. It's part of we all have pulse oximeters. So, and if they are especially from the hotspot areas, and if they have a history of COVID, then we would definitely run a CT chest for these patients.
So by and large, you would do a CT chest of your patients if they come in with a stroke. Would you put in the risk factors also? Sorry? You know, that was a nice term you used, the happy hypoxic, patients.
Because our patients actually with a saturation of 70, he was able to hold his breath for the CT. So that was quite remarkable. The other patient had a room air saturation of 93, which was also not good, but he was also able to hold his breath. And I was just wondering if an early stroke is like a marker for a severe COVID. It is obviously a thromboembolic phenomenon, and this could presage that these patients are going to have a bad COVID, perhaps.
Dr. Ojha, Pawan.
Yes,
Dr.
sir.
Ojha, would you like to make a comment or a quick question?
So I must congratulate both the speakers for really giving us the the real picture of the whole thing. Of course, we are all clinicians, and we keep on thinking about causality, association, and all those things. But I think my best approach to this is that uh, that there is a definitely some reduction, like 20% reduction in the overall incidence of stroke that everyone is reporting from everywhere. So it seems as if that the COVID is not definitely increasing the incidence of stroke. If you have a stroke and you don't have the real risk factors, then one must wonder whether these are being precipitated in some way by COVID. Whether you have respiratory symptoms or you don't have respiratory symptoms, patients who come in the hospital, we are taking them as a suspect COVID. So, and especially in such emergencies where you need to decide who will go in with the patient to thrombolyze or to the cath lab or in the CT scan, must develop protocol. So I think it's a good idea to treat all these stroke patients as suspect COVID and put proper PP. And once you take them to a CT scanner, finish off the low dose radiation CT chest. Right. So at baseline, obviously they do get a SpO2 monitoring, obviously, and that remains continuous with them. So, but if there is a possibility of getting an early report of PCR, that even doesn't rule out a stroke. I mean, that doesn't rule out COVID. Sometimes you get delayed reports like Madam showed us that on repeated testing then it comes positive. Nishant told us that it comes positive only in the IgM later. So having a negative report doesn't help us. So I would say that treat all of them as suspect. If he comes negative, congratulate everyone. If he comes positive, then you're all on the right track. So that is my take, and I'm sure everyone understands this. The only thing is Dr. Kaul was trying to be really more scientific and asking Nishant to, lay out the protocols.
Right, thank you. Pawan, I think that was a good comment. The basic thought I had was, is there a COVID risk score that would stratify risk and allow us to sort of not do it like a blanket and do it based on the risk of the patient having COVID and a stroke?
From the article from Mao, which was from China, the 221 patients, what
right.
they said is that those patients who are more severely ill, only they get the stroke. They saw in only that. But see the Oakley article, they have the cases who are not looking like COVID. So I mean,
who are asymptomatic, yeah, who are asymptomatic.
Yes.
Thanks for your comment. So I think we can just take a couple of questions. I don't know if we have time. I just asked the organizers, do we have a time for questions? Nishant, you can take a couple of questions.
Yeah, sure.
Yeah.
So there is a question from Dr. Amit. The question here is, how about using IVIG in patients with COVID and stroke?
Using IVIG with COVID, yeah. Any comments on that?
I found mention of that in the context of patients reported with GBS, where,
yes.
Yeah, but not in the context of stroke. So I just don't know. I don't think I'll be using in the context of stroke because it's a prothrombotic agent as well, and you are actually taking the risk of causing stroke. But that begs a question that one should be familiar with other stroke mimics, and GBS can potentially be a stroke mimic, and one may end up giving TPA to a poor guy who is actually coming with GBS.
Yeah.
Fair enough. Any comments on that, Uma? IVIG?
I think it's a logical question in the sense that IVIG being pooled plasma there might be anti-COVID antibodies to it. But the antibodies, if it's an antibody-related phenomenon, it would actually appear after about 2 weeks when the antibody starts. And we are seeing stroke in the early part of the disease, not in the later part of the disease. So I mean, I would not think that this is an antibody-related phenomenon, really, at least in the very limited thing that we have seen so far. Perhaps GBS, transverse myelitis, all these we might see as an antibody-related phenomenon when the IgM, IgG antibody becomes positive. That's at 2 weeks after the actual injury. But these strokes are occurring in the early part.
You mentioned about the Umapathi's article of previous original SARS.
Yes.
IVIG.
Yes.
Yes.
Yes, I did. I did. If you see that they have given IVIG and thought it's an autoimmune.
Yeah. And so I think we have run out of time. So, but it was a great talk, Dr. Nishant, Mishra, Dr. Uma, your experience, and Subhash. Thank you for joining us as usual. You know, stroke he's passionate about, and Pawan, of course. You know, thank you for being there, and thank you everyone who joined us for the talk. We hope
thank you so much.
We could throw some light on stroke and COVID.
Yes.
Thank you very much, and
thank you. Thank you.
Thanks for inviting me. Thanks.
Thanks.